But here we are talking about the hot topic of abdominal bloating, distension, and abdominophrenic dyssynergia. So the first thing to kind of talk about is a little bit about some of the epidemiology. And this is a paper that just came out 2022 in February. A really nice paper that talks about what this really is, what it means, and just kind of some five-prong approaches to working with people with this issue. So as I said before, 66 to 90% of IBS clients have bloating and distension. And Rome 4 was updated as a key feature of the IBS definition. So the thing that has always set irritable bowel syndrome apart from functional diarrhea and functional constipation has been visceral hypersensitivity. And now they've actually added bloating and distension as another key feature to move people from the functional, hyposensitive diarrheas and constipation into the hypersensitive, which is the key thing of irritable bowel syndrome. And the reason I bring up IBS is like, this isn't really a talk on IBS, it's a talk on bloating and distension and abdominophrenic dyssynergia, but these are hallmark factors of IBS. And the more we understand about IBS, the more we're going to understand about this. So make no mistake about it, IBS is simply allodynia. It is hypersensitivity of the visceral system. It has somatic sensitivities that go with it, and it is certainly central windup. I haven't seen any IBS client in all of my years of clinical practice that hasn't been able to tie the onset of their symptoms following some super traumatic event, whether it's their own physical trauma, whether it's an illness, whether it's an autoimmunity onset, or a huge stress piece. So there's definitely trauma and history back behind IBS, whatever way you want to define that. So just a couple of things here. Bloating and bloating is the hypersensitive sensation to lumen changes, basically without girth changes. So people feel like they've got distension, but they don't really have it, but they feel really heavy and big on the inside. And the definition of distension is the girth change. So you have the hypersensitive sensation to the lumen changes, but also a distended belly that you can measure. This article discussed 5 prongs, which is going to be diet, SIBO, small intestine bacteria overgrowth, constipation, visceral hypersensitivity, and of course, abdominophrenic dyssynergia. In the article, they go through and kind of separate all this out. This is kind of what we'll be considering tonight as we've talked through, because there's things that we can do in a lot of these treatment categories on the right-hand side. So they look at, are there dietary culprits? And so if there are, we're going to restrict lactose, fructose, or basically the high FODMAP foods. Gluten after celiac testing, there's a lot of things that we can do here. People with true IBS really tend to respond well when we remove the foods that are rapidly fermenting, which puts a lot of air in the lumen quickly, or foods that draw a lot of water into the lumen super fast. So we want to think about those, and that's one of the things they talk about in this paper. Is constipation present? If so, we're going to pursue treatment and consider pelvic floor outlet dysfunction as well. Are there any symptoms owing to SIBO? So we want to consider treatment or testing with that, and I'll go through a little bit more of that, but that's when we look at strictures, lesions, and poor stomach acid. All contribute to small intestinal bacteria overgrowth. In other words, undigested food is getting into the small intestine, or foods that are getting into the small intestine are slipping into like endo lesions and a nice environment for bacteria overgrowth to occur. Are symptoms consistent with visceral hypersensitivity? So if so, consider treatment with a neuromodulator, or in our realm, in where we work with pelvic health, is also considering all the down training, the stress mediators, all of the different pieces, sleep, everything that goes with that. And this is a huge piece with abdominal bloating and distension. Although sometimes it can occur in a hyposensitive area, it's generally considered very, very present with visceral hypersensitivity, making it like double difficult to treat. And then are symptoms consistent with abdominal phrenic dyssynergia? And so in the article, they wrote treat with biofeedback therapy. I'll go through a little bit of what the literature tells us about that, but I'm also adding in, we need to look at neuromotor control of the abdomen and the diaphragm and what's actually happening there and how we can get that motor system to change. So I added that piece in to this because I thought it was very important. So there's old misconceptions and current knowledge. And a lot of this article was talking about different things that they looked at in all of the cases and some of the articles that they looked at here. And they have a nice table where it was all beautifully distributed out. So they talk about increased bowel wall tension. And so that's gastric and intestinal expansion by swallowed air and CO2. Expanded intestinal fluid load by foods that bring a lot of fluid in. So when we think about certain types of fibers, they're designed to bring a lot of fluid into the lumen because they're trying to soften the stool. So we look at, do we have a colonic accumulation of packed stool? In other words, do they have colonic inertia, or do they have functional outlet obstruction, or do they just have impacted stool up into the descending colon or even higher? And then do we have endogenous gas due to fermentable foods, gas producing microbiota, and maybe microbiota that is not there that's supposed to help reduce gas. So it can be kind of two on, on either side, and then impaired intestinal gas diffusion. So it doesn't really move the gas through well, and it becomes very uncomfortable and, causes a hypersensitivity buildup around the neuro region of the colon. And then we have, a perception of wall tension. Do we indeed have intestinal wall inflammation? Do we have neurosensitization? And remember, neurosensitization can occur at the local spinal and the brain circuitry. And then emotional, stress, anxiety, somatization, and hypervigilance. And finally, other things like circadian rhythms, people who do shift work, there's a lot of things about messing with our circadian rhythms that messes up our neuro pathways and our sensitivities, fatty meals, intra-abdominal adipose tissue, and perimenstrual. So in and around the menstrual cycle as well. And then we also have aberrant conductal maneuvers in response to bowel stimuli. So in other words, dyssynergia at the outlet, pelvic outlet, but we also have thoracic expansion, diaphragmatic descent, and abdominal muscle relaxation that begins to occur. And we're going to go into that with just a little bit more detail as we move forward. So this is the bottom piece here is going to be talking about our abdominal phrenic dyssynergia piece. Okay, so we talk about SIBO. We want to think about the following things. Do we have strictures? Do we have reasons for strictures, especially in the small intestine? And endometriosis, bowel endometriosis can be certainly one of the things that can do that. We can get strictures from other things, from scar tissue, from diseases, from IBDs, and, which is can use an autoimmunity that can cause that as well. The other thing is we can have stomach hypochloridia. And and a lot of times, one of the things that they'll do is put people up because, that when we have stomach hypochloridia, we have dysbiosis, we have constipation, and we don't have enough stomach acid to actually digest the food. And when our stomach acid is decreased, one of the things that happens is the cardiac sphincter, which is the sphincter on top of the stomach, doesn't close off. So we need chewing of food and salivary enzymes, digestive enzymes, to be going down the esophagus as we chew. That kicks on the stomach acid pumps. And the stomach acid pumps, as the food enters, start raising up their acidity, or I guess lowering the pH, raising up the acidity, lowering the pH, enough to, when that happens, when it gets to a certain point, it actually closes the sphincter off. So the stomach acid stays inside the stomach and does its job. It breaks the food down enough to where a lot of our essential minerals are digested and pass through the stomach wall, which are going to include important things like how the calcium gets out and gets to our bones. So unfortunately, when we don't have enough stomach acid, we have a lot of GERD. And what is the treatment for GERD? Proton pump inhibitors, which just makes the situation worse. So what we need to think about is, what can we do to help increase people's stomach acid in a way? And they've got to get through getting off of the Nexiums and the Pepsids and things that they're on. And it's a difficult thing to do, but it can be extremely helpful. And then we can start doing things like adding HCl or betaine challenges, 1 meal a day, kind of working up to where we can start building up the stomach acid. Maybe they need a few more digestive enzymes. That's something that I work with the functional medicine doctor to determine what, kind of protocol we're going to put them on to get them moving forward there. And then we're going to look at the movement system changes, which we're going to talk about with that abdominal phrenic dysinergia, to see if we can't start getting some of that going as well. So this is just another slide to just kind of show what I was talking about. So the lower, if you see here, the picture on the right, you've got the sphincter closed, and then the picture on the right shows the sphincter opened, allowing reflux to come up. And so it also, when we have stomach hypochlorhydria, we have bloating. So it's what happens afterwards. We have diarrhea, acid reflux gas, undigested food in the stool, which means we have undigested food getting into the small intestine where it does not belong, and can have the ability to have a bacterial overgrowth. Could be nausea, could be some nutrient deficiencies, and then the stuff that we see a lot with inflammatory processes, hair loss, brittle fingernails, things like that can go on. So when we're talking about endo and IBS, we're thinking endo and bloating and endo and SIBO. So some of these things are kind of like all intermixed together. But that one of the studies that they did recently in July of 2022 is they really wanted to look at how much of people with endo actually have, how many of them are really going to develop IBS, and should we be looking at this more across the table and not just saying it's either endo or IBS. And some of the stuff that they found in this systematic review and meta-analysis was that patients with endo have a threefold risk of developing IBS. I think we as practitioners already know this, but I think it's great that it's finally starting to get up there and really having people look at this. And one of the things that I thought was nice in this article that led up to this study was one of the articles that they cited. Possible explanations for this included low-grade inflammation resulting from mast cell activation, neuronal inflammation, leaky gut, and dysbiosis. So we've got impairments of the colonic walls breaking down. Stuff is getting into the bloodstream that doesn't belong there. We've got neuronal inflammation, which means that we've got hypersensitivities being set up at the level of the lumen, as well as probably at the spinal cord and probably in the brain. And then mast cell activation is the byproduct of having things in our blood supply that doesn't belong there, because now we're having the cells that are supposed to reduce, and fight against these types of things are being activated, and mast cell activation can lead to a whole host of issues and problems. And I'll touch on that in just a few minutes. Just a nice little kind of comparison chart, I think, can be helpful, but again, these can cross over. So you can look down the list of IBS, which means, IBS is chronic. It's generally moderate amount of pain, and it's oftentimes more up into the upper part of the abdomen. I've seen it in both places though, but it tends to be more moderate and less acutely severe. Small meals fill people up faster. They have a lot of nausea, sometimes with eating. They definitely are plagued with GERD. Administration increases bowel changes. So in other words, the onset of menses, if they're IBS constipated, they're going to turn into IBS diarrheal. And then at the offset of menstruation, when it changes, they go back to being IBS constipative. So they have those bowel changes around their menstrual cycle. If they have any anal bleeding or bleeding out of the back passage, it's usually due to tears or hemorrhoids. And dietary changes really do help reduce symptoms. So looking at that low FODMAP, what do we need to remove? The rapidly fermentable, foods, or the foods that have that osmolality that's going to pull a lot of liquid in quickly. The symptoms with IBS, once it sets in, they really don't change a lot. They might get a little better or worse during the day, but they very rarely go to where we don't have any at all, and then all of a sudden we have terrible pain, and we don't, it stays unfortunately very stable. With bowel endo, which can be part of IBS, but can also have its own pieces. And this is what the article talked about. It's like we have to be better at really recognizing who needs to be worked up for endo. And so they tend to have much more chronic and severe abdominal pain, and particularly in the lower abdominal pain area. Menstrual irregularity, extreme pain on either side of the menses and during menses. Pelvic pain is more prevalent in endo with sex, sitting, rectal and vaginal. Of course, we recognize that. If there's any bleeding out of the back passage, it's generally associated with menses, which means that the inflammatory process of menses with endo the lesions can become very sensitive and could actually bleed with bowel movements and things like that. Infertility, subfertility, multiple miscarriages, and dietary changes are not as helpful here. Yes, we can reduce some inflammatory load on the system, but they're not going to be as noticeable as with people who are just IBS without endo. And of course, with endo, symptoms do progress over time. So just kind of a nice review of what does that mean and what can that do for us. So as we walk through this part now, I'm going to tell you a little bit of a story. But this is an article about definitely abdominal phrenic dyssynergia in patients with abdominal bloating and distension. It's a little bit of an older article, but it's a very important one because I think it has a lot of really good things to say. Basically, what they talked about here, this is what they looked at. In healthy subjects, colonic gas load increased girth. Okay, so in normal, healthy people, we have gas in our colon, it increases the girth, relaxes the diaphragm, and increases the anterior abdominal wall tone. That's how normal people cope with gas. It helps move the gas through. With the same gas load, clients with bloating and distension actually had significantly more abdominal distension, so they really distended out. And this was associated with contraction of the diaphragm and relaxation of the internal oblique muscles. And so what they wanted to look at was they wanted to look at a provocation model by adding gas in and seeing how people coped with it differently. So if we're going to go on the assumption that people were having pain with this, I want to compare what happens to the dyssynergia with the diaphragm in patients with the chronic, the chronic bloating. And I want to compare that to an article by Kohler in 2012, which actually looked at the position and excursion of the diaphragm with those with chronic low back pain. And what they found in this article, they basically put people flat on their back in a functional MRI, and they had them raise their foot, 10 inches off the bed, and they resisted it. Same with their arm. And they compared people with chronic low back pain to people with no pain at all, no back pain at all. And what they found was that even at rest and with normal, just regular breathing, the people with chronic low back pain had a diaphragm that was constantly being, that was already contracted, and it was stiff. It didn't have great excursion, and the position of it was different. The crust, which is the part around the esophagus and the aorta, was standing up higher in patients with chronic low back pain. The postulation is there that the diaphragm is behaving as a postural control muscle. And then, of course, under load, it was not able to, to really step in and do some of the stuff that we want the diaphragm to do under load, which is act and defend in a little bit of postural control. So the diaphragm, kind of like a pre-contracted or a over-recruiting pelvic floor, which doesn't have great motion, the diaphragm can get that too with pain, and particularly around and in the spine. So when we compare that with this article here, you can look at these pictures here and we can see what actually is going on. So they put gas, normal gas, into the system, and in a normal viscerosomatic reflex, you get the diaphragm actually raising up or ascending. It's relaxing. Remember, a diaphragm that's kind of rising up is one that's relaxing somewhat. The abdominal wall muscles, particularly the ones in front, the anterior abdominal wall muscles, will tend to have a little bit more tone. Okay, and that allows for expansion of the gas to go up and also for it to go down. When we have an abnormal viscerosomatic reflex, we get a contracting of the diaphragm down, And actually what ends up happening, rather than this working with the pain, it actually starts to release and relax, because the system is trying to get this away from the visceral system. In other words, the client neural system is trying to move that system away so that we don't have that pressure onto that lumen that has that hypersensitive reaction to gas or liquid in the lumen. And so thus giving us a lot of girth changes with the diaphragm that is definitely descending, contracting. And when that happens over time, as we learned in the Kohler article, that the crust of the diaphragm comes back up against the spine even more, making the rest of the diaphragm as it contracts flatter and less movability. So we end up getting stiffness in the intercostals, we get stiffness in the lower ribs around the diaphragm, and we have all this abdominal wall relaxation that's going on. So we've got this very uncomfortable bloating situation, and it just makes, so that's kind of what we're seeing here with the dyssynergia. Does anybody have any questions or comments on that before I move back into the next part?
There's just a few questions in the chat, not necessarily about that abnormal viscerosomatic reflex. We can hold them till the end, or we can go with them now, but
are they about the activity we were just talking about? Or are they okay? Yeah, let's wait just a little bit then, if it's okay with everybody else. All right, so the article, the very first article I showed, talked a little bit about biofeedback in the literature for this abdominal diaphragmatic dyssynergia, or abdominal phrenic dyssynergia. Basically what they sought to do in this particular article, which was in 2015, they wanted the clients to voluntarily reduce the activity of their intercostal muscles and diaphragms while increasing activity of the anterior abdominal muscles, particularly during expiration. So basically what they're trying to do is they're trying to get that change happening. They wanted them to, as they exhaled, they wanted them to use their tummy muscles a little bit more and allow their chest wall to relax. And so they put electrodes on those places. It was really hard to find exact electrode placement. The article just talked about that they put it on the stomach and they put it on the thorax. And they at first did an intraesophageal kind of one as well. They figured they didn't need that one. They took it away. So thinking about our clinical biofeedbacks that we have, you certainly could, put a couple of electrodes on the thorax. I'd put them laterally myself, where we could really get, see if that basilar movement of the ribs could reoccur again. And we also, and you can put them on the anterior abdominal wall and just see what's happening. And they did that for them to, they did that in this article, EMG, so that they could see that there was a lot of noise. I mean, that the noise was all up in the intercostals and there wasn't a lot of noise down below. The problem is when we have these great research biofeedbacks, they have the ability to get rid of artifacts and change things up, and our clinical models aren't quite so sophisticated. But they did do this for 40 minutes, which I thought was interesting, and they had some good results. It was a small study with not a lot of people in it, but it did, render some interesting things. So one of the things that I consider with this population, and this is how I still work with it today, is my goal is to reduce oblique and diaphragm overactivity and then retrain that. And the reason that I say reduce oblique is I see some obliques really kicking in with this. I see the distension really going out anteriorly. A lot of women will think that it's, that they have a DRA with this, because it is so anterior with it. And so there's kind of a concomitant, like almost hanging on with the obliques. But my goal for these people is to just kind of switch that up a little bit. So I want them to learn to fully, so I have it in 3 things here that you can see. I want them to learn to fully relax the abdomen. So I tend to put them in quadruped or a forward lean over a table with their knees relaxed. So not everybody can get on their hands and knees, and not everybody's comfortable on their hands and knees. So they can lean on their forearms, you know, over a table, or, you know, or they can get on hands and knees. And generally what I do is I'll take my hands and put them around the rib cage, particularly on the lower sides of the rib cage. And we'll just do some easy work there first, just to get them to kind of breathe. I want them to breathe into my hands, and I want to get them out of belly breathing, because I see an inordinate amount of belly breathing in this population. Like, it's all belly breathing, and it makes sense to me, because if the diaphragm is over recruiting and flattened, it's not going to move well. So they have to use the belly to bring the air in. They already have pressure in their belly. And remember, the belly is supposed to be, the abdomen is supposed to be a low pressure organ. And so when we have a pressure in the abdomen raising up, we're going to have a concomitant overpressure, or an increasing of pressure in the thoracic cavity. This is one of those things that happens. And again, the load down on the pelvic floor becomes higher. So the pelvic floor is either going to work hard to press up against that, or it's going to let go and not work. And we've seen that happen a lot in both situations. So I really want to work on getting that lower rib cage and obliques to let go, so I can come in beside them or behind them with my hands around the rib cage. We can work on some rib cage breathing, and then we're going to just allow them to really let that abdomen drop all the way down, not push out, because they're pushers in their abdomen, but just let it really kind of relax and hang. It's tough to get there. So I'll put one hand underneath the abdomen as they're kind of breathing. And as they relax, I'll just say, just keep dropping your belly into my hand, and we'll just keep lowering down till we get that belly nice and relaxed. And then from there, we can use a little exhale, or you can use a little low registered humming, because I don't want it to be a heavy exhale. But I want them to really begin to start to think about lifting their anterior abs towards their spine, just gently, as they exhale. And that's going to help the diaphragm let go. You know, we're going to go across that reflex that we have there and really help that to work. So they can, and then they let go again, and then they can lift up. And I always want it to be with an exhale or a low registered voice, because if you are talking, you're not holding your breath. And these folks are big breath holders because of this type of dyssynergia that they have. And then I want them to be able to release and recruit several times. And again, you're there working with them, watching for unwanted movement patterns. Are they arching, hyping their back up too much? What are they doing? Are they really just kind of working the area that we want? They're not going to be great at it in the beginning, so we just keep going till it gets better. As soon as I can get this working, I get them up. We're going to retrain in either a seated, a standing, a back against the wall. What other positions might be meaningful for them? So in the seated position, perhaps maybe I'll have them sit with their knees a little bit further apart, so that there's room for their abdomen to move. And I'll, get on the side of both of their, lower rib cage there, and we'll work on just in this position, just see if you can let that abdomen come on out. I almost give them cues like, pretend like your abdomen is a hand that's holding a ball inside of you. See if you can have the ball be presented out to the world, so they can kind of like lift the ball up and in and let it out and down, and give them that help there as they're working on exhale. And then adopt a better position for eating. All of these people, and especially in Western society, I see this constantly. Nobody has a motor plan for the fork or their spoon or their hands past the midway from their plate to their mouth. So they all can lift it up halfway, and then none of them lift it up the rest of the way. What do? They drop their head and mouth to the fork or the sandwich or whatever may be in their hand. And I see this constantly. And so this is like, how can we get things to operate better if we're constantly putting ourselves in a position where the motor system is collapsing, and trapping, and we don't have food going down easily because it's having to go through this big kink in the system to get down there. So we start over recruiting, we start swallowing harder, We start belching more because we're trying to open that area up at the top where the esophagus meets the stomach. And that just really kind of starts feeding into these abnormal movement patterns. So I want to think about adopting a better position. So I'll have people sit and tell them at home, what I want you to do is I want you to put a pillow or a towel behind your back, like just fold it up, put it behind your back and sit against it. Yes, it's a extreme position, but I'm trying to make a point that see how long you can keep that there before it falls out. And usually within the first 2 minutes, it falls out because they start going back down to their food. Can't help it. Classical conditioning. We've got that motor system laid down that way. We're all eating on the go. We're all eating fast. We're all doing all of this crazy stuff. So I really work with them on this. The other thing that I do, because I know everybody's going to like say, what about the thorax? You know, and I'm a big believer in rotation. And I'm a big believer that thoraxes get very, very, very stiff. They get stiff pregnancy, postpartum. They get stiff. They get stiff in men. They get stiff in women. It's an area where we just have a lot of stiffness. And if we think about it, so if we're thinking about hypersensitivity and sympathetic versus parasympathetic and eating, which should be a very parasympathetic activity, before they eat, I want them to do some movements that are going to be very helpful for them. And I don't care how they do it. We play around with a lot of thoracic rotational movements. They can put their hand on their wall and reach underneath their arm. They can reach back. They can sit at the table and they can put their hands on the table and rotate head and thorax. They can lay on a towel roll and raise their arms up and down and do snow angels, and they can lay on their side and reach across. I mean, you all know all the thoracic mobility exercises, but this is where it really counts, because as we'll make the case as we move forward, this is all of this stuff around IBS and distension and bloating is all occurring around the time of eating and also near the kind of the end of the day, when we're much more sympathetic than we are parasympathetic. So they all wake up in the morning, they feel a little bit better most of the time. There's always going to be 20% that are more complex. They all feel a bit better. Everything's fine. After lunch is when it all starts. And that's after the allostatic load of sympathetic overdrive and what they're doing and the stress of their day, all of their stuff really starts happening. The other thing for a lot of these people is they're not moving. So on top of it, besides the poor eating patterns that they have, they adopt the same pattern at the computer, or they adopt the same pattern over the work table or workbench, or they adopt the same pattern chronically if they're leaning over the surgical table. This is not, this is an equal opportunity postural dysfunction that occurs. I don't care if you're on the assembly line or if you're, working in a laboratory leaning over a microscope. It's just thinking about chronic postures and chronic things, which is why I really want to spend time with them when they're having the symptoms or before they start to have the symptoms, so we can start down regulating as we kind of move forward and bringing it into their day all the time versus just a nighttime 20-minute session. I talk to, with the younger people, it's easier, but I think older people binge watch now too. But I always say, this is not a program I want you to binge watch or binge do. I don't want you to just do it at night or just do it in the morning. I want you to break it up and let's do it across the day, little pieces and parts, so that we can follow kind of a little bit more polyvagal-ish challenges to the sympathetic system to get it to let go.